like one of those talk show guys. I felt like I was on his talk show. I thought it was really cool.
So,
Hey, how are you?
pretty good. How are you?
Doing good. Doing good. All right. Well, it looks like it's 8 o'clock. So everybody, on behalf of OPA and the board, we'd like to thank you for being here this evening. Tonight's presenters will be Dr. Jim Broyles and Dr. Matt Capizzuto. The topic will be how to survive the pandemic. OPA answers your questions about the rapidly changing landscape of insurance regulations, HIPAA, and telepsychology practice during the current crisis. If you didn't already hear Dr. Broyles, if you would be so kind as to mute yourself during the presentation. We will have time at the end for questions and some discussion. And again, we're looking to go from about 8 to 9:30 at the latest. And at this point, I'll just turn everything over to Dr. Broyles. Thank you.
So I'm really hoping that, you know, at this point, we have a lot of people who are sort of up to speed with, you know, where we are with some of the changes that have been happening. So my hope is that one of the main benefits of this meeting is going to be that it'll be the opportunity for you to ask questions. And so I'm going to go over just a little bit about, you know, just some of the main ideas with the changes that have happened with our rules and regulations. And then Matt is going to talk a little bit about some specifics of telepsychology, teletherapy, and some of the guidelines around that, which I am not an expert on in any way. And so maybe between the two of us, we'll be able to cover a lot of bases. And I don't think that'll take a whole lot of time. And then that'll give all of you an opportunity to ask whatever questions you have, okay? So this is a repeat of some past meetings that we've been having since, I think this is probably like our fourth one, I wanna say. And we've been having them over the course of probably like the last 3 weeks. When we first started these, there was a lot of information flying around, a lot of chaos, and a lot of confusion. So one advantage that I have as your Director of Professional Affairs, you know, my main job is to sort of watch over our insurance world and give you help with that when you need that. And so during the beginning of this whole crisis, there were lots and lots of changes that were happening at that time that affected, you know, our practices in terms of laws and rules, regulations, insurance, and all of that. And I spent a lot of time just trying to track that and, you know, sort of digest it and get you that information so that you could have that. As a result of signing up for this meeting, you should have received a handout, and on the handout, it actually has some links to our resource page, which right now has a lot of good resources on it. It also has a direct link to my blog. The link to that is also on the resource page. And my blog has all of the updates that I've given so far about changes with specific insurance companies, with Medicare, with Medicaid, with laws that are affecting our practice. And at this point, the specifics of all of that are like way too much for me to be able to cover with you here tonight. But again, you have that in your handout, the link to my blog with all of that information. And then if you have some questions about a particular company or a particular procedure, tonight would be a good place to ask that. I'm just not going to go over all the specifics of all of that stuff that I've been sending out. So the one thing for us to keep in mind is that's most helpful is the laws and the rules that affect us are coming from a lot of different places. That's always true. I think we're getting some feedback here, some background noise from someone. There you go, someone muted, that's great. So the laws and rules that affect us, and this has always been true, come from a lot of different places. You know, they're coming from federal law, state law, the rules from the Board of Psychology, which is also state law, and the many insurance regulations that are specific to insurance companies, Medicare and Medicaid. And so the problem that we run into is when massive changes start happening, temporary changes like the ones that we've just been going through, everything is affecting everything else. And so it's very difficult to get like a whole comprehensive view of all of that. And in some cases, with some of the things that we're dealing with, there isn't a really clear, definitive answer. Although I will say, since the time that we've started these meetings about 3 or 4 weeks ago, we do have more definitive guidelines than we did, at the beginning. But because the changes there's so many changes coming from many different directions, and everything is affecting everything else, sometimes it's hard to pin that down. For example, there's still some rules or guidelines in some places with some insurance companies, for example, might say, hey, you need to be following HIPAA guidelines, but then HIPAA guidelines have specifically been altered for all of this. Okay. One of the things that I would say that I've noticed to be true is that within the governments, within the insurance companies, we have seen, an attitude of mutual support and an attitude of wanting to make adaptations to make this as streamlined as possible. And I feel very encouraged by this. It's like everybody's so willing to help everybody else. I just hope we keep that up. I think it would be a really good thing. Right now, at this point, as I mentioned before, changes are becoming less frequently. So our regulatory environment right now is starting to stabilize. Okay, I'm continuing to monitor as closely as I can any changes that feel relevant for us. I've got good contacts with the insurance companies, very direct link to our State Board of Psychology, and a lot of support from APA and my Director of Professional Affairs counterparts at APA. So, and our legal and regulatory affairs staff. So I'm really networked well with a lot of different places to kind of keep monitoring any changes that might be occurring, and I will still monitor that. What I'm asking right now, we went through sort of a period of time where people were using the listserv a lot to ask questions, and then people were trying to answer to, and that was really wonderful that people were trying to, again, have that effort, that attitude of mutual support to help one another on the listserv. What I was noticing is that sometimes the answers were not quite correct and then contradictory with other things that I might be sending out, and that was causing some confusion. So the one thing that I'm asking everybody right now is, if you come across something that feels like an update to information that I've already given out, please go ahead and send that to me. I'll do my very best to vet that information and source it and then kind of get it out to you. An important idea that we want to just be able to go over here, emphasize, is that all of our Board of Psych rules still remain in place. So in other words, none of that has been altered. None of that has been adapted. Okay. And so the one that's most affecting these issues that we're talking about here tonight are the rules around providing telepsych or teletherapy services. All of those guidelines that govern us in that area remain in place. However, the guidelines that are there are, those guidelines are a little bit broader than what we experience, say, for example, from the insurance companies. So there's a lot of latitude with it. But our Board of Psychology does consider telepsych to be a area of specialty, and the Board of Psychology does want you to get some special background and training in this area before you just jump right into providing these services. Now, having said that, there is no specific guideline right now that says, hey, this is the kind of certification or this is the kind of class that you should have. It's just a requirement that you just follow the standards for the industry when it comes to providing, telepsych services. Now, if you go to our resource page, the OPA resource page, you will actually see some documents there that outline what good training should probably cover. So that could be used as a good guideline. And you will also find some, links to free training resources through the American Psychological Association. So that would be just a really good your best bet to making sure that you're covering the base in that area. So I'm hoping that many of you have heard by now about the issues that we're having with HIPAA. So obviously, you know, or maybe not so obviously, when you jump into this area, one of the things that you notice is that there are some pretty strict guidelines that affect the technology that you should be using. And one of those guidelines is that, you know, when you're providing services on the internet, that you should be using, you know, some HIPAA compliant web-based platforms when you're communicating with your patients. So clearly in this crisis situation, that has become, or, you know, has had the potential to become an issue. The problem is that there's not often, people don't always have access to those HIPAA compliant platforms. And the other concern has been that everybody is, you know, through teletherapy, telemedicine, is going to be reaching for those platforms to try to provide services right now. Even your family doctors will be doing that. So the concern, I think, part of it is that some of those HIPAA compliant platforms that are more specialized will be crashing or have been crashing or might have some technical problems. As a result of that, and in anticipation of that, about 2 or 3 weeks ago, the Office of Civil Rights and the Federal Department of Health and Human Services, who are responsible for enforcing HIPAA, did a temporary revision to their guidelines, okay? And essentially they're relaxing some of those restrictions on the technology that we use. And I'll read to you directly what their most recent statement has been. During the COVID-19 national emergency, which also constituted a nationwide public health emergency, covered healthcare providers subject to the HIPAA rules may seek to communicate with patients and provide telehealth services through remote communication technologies. Some of these technologies and the manner in which they are used by HIPAA-covered healthcare providers may not fully comply with the requirements of the HIPAA rules. The Office of Civil Rights will exercise its enforcement discretion and will not impose penalties for non-compliance with the regulatory requirements under the HIPAA rules against covered healthcare providers in connection with the good faith provision of telehealth during the COVID-19 nationwide public health emergency. This notification is effective immediately. So when that statement was issued, our attorneys at APA went into action and really kind of perused it very carefully and gave us their best shot at interpreting guidelines for us. And what they're saying right now is essentially, when you're attempting to provide teletherapy, if you're making a good faith effort to identify and provide services through a HIPAA compliant platform, and that is not available, or there's something wrong with that, then you need to proceed and use something else. So, you know, that's their basic guideline. In general, insurance companies have really scrambled to revise their policies. And I would say, you know, most of the major insurance companies have undergone some kind of revision. And so again, if you go back to that blog that you have a link to now, my blog, you'll see some of those very specific updates. There have been all kinds of changes that have been made to their regulations. So for example, many of them required you to provide an attestation before you went ahead and jumped into providing teletherapy services. And those requirements have been dropped. Many of them required you to use their own web-based platforms that they provide for you, and those requirements have been dropped. Many of them have at this point made the reimbursement rates for teletherapy comparable to you know, the face-to-face services, and that really wasn't the case before. Many of them stipulated that when we provide teletherapy services, it must include, the old regulations said they must include both visual and an auditory component. And many of them have dropped that requirement, and they're allowing us to provide, you know, teletherapy through audio means only, which means you could even call your client and provide a session on the phone if that's the only means that are available to you. That's kind of consistent with what we're hearing from our Board of Psych too, because what they're saying to us is, hey, we're in a crisis, and your first priority is to make sure that you're providing for the needs of your client. This is a crisis situation, and let that be your very highest priority. Now, there's been a lot of talk and a lot of concern with some of this with Medicare specifically. Medicare and Medicaid, which is governed more in the state of Ohio, has also revised its guidelines, and those guidelines are very consistent with some of these things that I've already mentioned, okay? Medicare has done some revision, and those guidelines are administered more at the state level. And so Medicare at this point has done some revision. Their old guidelines used to say, yes, if you're a Medicare provider, you can go ahead and provide teletherapy services to certain populations in rural areas that are more remote, where people don't have as many access to any other kinds of help. And even then, they have to go to their doctor's office to receive that. They can't just be at home doing that. So those were the old guidelines that we've been really kind of battling with, as a profession, trying to get that loosened up. But temporarily, they've issued new guidelines that say all Medicare recipients may now receive teletherapy. They're permitted to receive teletherapy, and they are permitted to receive that teletherapy in their homes. They don't have to go to a certain location. Now, the problem that we have right now, and what we're battling with, is that they're still stipulating that that the provision of those therapy services must include both a visual and an audio component. So that means that telephone-only psychotherapy is not being permitted to Medicare recipients, okay? And we've been advocating for that. APA is doing battle with them on that, really advocating for, helping them to understand that this is a really serious problem. Because most of us who are Medicare providers know that the Medicare recipient population, many of those folks don't have as much understanding or access to technology as other people do. And so for them to actually hop online or use a smartphone, those things can be very difficult for them. But so far, we've seen no revision in that. That's Medicare only, still requiring that visual and auditory component. So, that really continues to be an issue. I really hope that it changes. I can't really say for sure at this point if it really will, because the battle has been fought here for a while. As I said, many of us know that that's an issue. So that's basically my overview and some of the important things I want us to be able to keep in mind. And I'm going to let Matt talk now a little bit about some of his important things that he wants to tell us.
Thanks, Jim. I don't have a whole lot in the way of an introduction, other than that, obviously, when we're thinking about telepsychology, telehealth, we're kind of in a unique position right now because we all had to kind of jump into this. And of course, not everyone has had a lot of training. Some people might not even been considering doing telehealth, but of course, to continue to serve your patients, you have to, for the most part. So the law has not caught up to the technology, and that still is what's happening now, as you just heard Jim describe. And I think that's where a lot of the fear rests with people with feeling comfortable jumping into this. But now we're kind of in a safer space with that, because the enforcement of those rules is going to be a little bit relaxed as long as we're serving our patients. But that doesn't mean we go out there like a wild person and do whatever we want and don't consider HIPAA and all the other rules. So, that's kind of stirred up some anxiety, and as much as it's resulted in people being a little more comfortable using this delivery method. So I've been doing telehealth, our practice, I should say, has been doing telehealth for a few years off and on, but we were going to formally launch our program in about 3 or 4 months, up to 6 months. It depending on when the platform we're using would be integrated into our EHR system, but we had to also expedite our program. And I know that was very difficult. So if you're in an agency and you're doing it from an administrative perspective, there are lots of policies and procedures that we follow with the agency, with the state rules, with the federal rules, and the different licensing board rules. So, I can help you from that perspective, in addition to kind of dealing with some of the nuances that this delivery method encompasses. For example, the 800-pound gorilla in the room is that you're in a new forum with your patients. So that's the first thing you have to talk about with them. And I often check in with my patients halfway through the session or whenever I get a chance, and at the end, at least at the beginning here, I've been checking in with them at least 3 or 4 times on how this is for them. The other thing is, you're on sensory overload when you're using all this technology. It is very different from sitting in the therapy office. But interestingly, when I'm doing an anecdotal survey with my patients, we kind of all agree that it really has been pretty good, and the sessions have been pretty darn good, and not much has changed. In fact, some of the sessions have been a little more productive, and I have my theory about that. A patient of mine and I were talking about that, why we think that is. We both agreed. We both came up with our own theory. So these are the kinds of things that you can explore with your patients when you're doing telehealth, and you actually might find it to be pretty interesting. So in some ways, many people think this would be a hindrance, but in other ways, if you look at it differently, it can actually facilitate therapy, especially when you're reconnecting with your patients, because we're all going through this crisis. So they know you're going through it with them. So it kind of does help make a connection with them. So a lot of semantics to consider. This isn't going to be a clinical, I guess, questions and answer or clinical consultation, although I'd like to have those in the future. But for now, I think we're just kind of getting everyone off the ground. Some of you are already doing telehealth, I'm sure. Maybe some of you haven't taken the plunge yet, but hopefully I can answer some of your questions. And I am very familiar, like Jim is, with the laws and rules around all that and how to navigate those. So that's really all I have. And I'll just kind of stand by and wait for questions to come in.
So, questions or comments about what you're learning so far, this new environment that you're in, difficulties that you're encountering?
Yes. Can you hear me?
I can.
Okay, I'm Gary from
Hi,
Cincinnati.
Gary.
Hi, thanks for doing this, number one. Secondly, I never thought of this until right now when you started talking about this specialization in telepsychology. And the question is, when we renew or update our license registration, and we put down what the specialty areas are that we have, has there been any discussion about whether we need to enter telepsychology when we feel like we've become proficient in that? Is that an issue that's been discussed at all?
I don't know what you mean about, is it an issue that's been discussed?
Not so much has it been an issue that's been discussed, but is there a need for each psychologist to contact the board and say, like in other areas, like if I provide family therapy or I provide psychological testing or couples therapy, is there a need to have that on my registration?
Well, so, if I'm remembering right, when we renew, there's an opportunity each time to declare your areas of specialty. And I believe this is one of them.
If it isn't, there's an other space that you can type it in.
Right, but there should be, I think it should be on there. Do you know what I'm saying, Gary? Like when
I know that, but is there,
areas
what I'm asking more specifically, is there a need for us to give information to the board before that renewal?
It's no more need than any other area of specialty that you declare. Because we declare areas of specialty. Do you see what I'm saying? Each of us are declaring areas of specialty each time we renew our license. We're not but that's all done on sort of like the honor system. So the only time that the board would ever get concerned about that would be as if a problem comes up and an individual case is investigated, because the board's kind of a consumer, protection group or, agency. So if a problem would come up and that problem is investigated and they're saying, oh, we're providing, some services in this area, right? And you've declared it, I see here, as an area of specialty. Now let's get together with you, Gary, and you show me what you've actually done in terms of your training and supervision to qualify as a specialist in this area. Do you see what I'm saying? And that's just the case for all of our specialties. I mean, not just this one.
Thank you.
Yeah, and essentially, and technically, you're developing a new competency. So competency is on the way to specialty. I mean, obviously, and that's what these consultation groups are. One of the reasons these consultation groups exist. You know, the other reason is to provide everyone with education. So, you know, I don't know that you could use this as a formal consultation, but it will get the ball rolling.
We are providing consultation groups through the association right now.
Right.
We're organizing groups where people can, you know, check in and get some consultation, and that's just one more layer of, you know, support to sort of identify you as a specialist in this area.
Right. So what I do recommend, even though the guidelines aren't really straight, they really are kind of not, I wouldn't say in the gray area, but they aren't really well defined, like what courses to take and how you would demonstrate academic competence. What I did with our agency is I required everyone to take a certification course from an accredited place, you know, APA or OPA accredited, that offers CEUs, and whatever the education provider designated as their certificate of academic, you know, technically academic competence is what I made them do. They could pick like whatever one they wanted. And, you know, so they all did that. And the one that I did in person years ago, it was actually online now. And that's the one that was offered through APA for free, which is an unbelievable deal. But some of the other ones took the Zur Institute. The one I took years ago and that's online now, it was like 3 or 4 years ago, is the TBHI, Telebehavioral Health Institute. Whichever one you can get some kind of documentation of an academic certification is what I would do. And one is 12 hours, one is 26 hours. I don't think an hour is enough. You know, I think that the basics, I don't think I would say that's enough, even in the crisis. I mean, I think not before you start, but as you get rolling, I would say, you know, get educated as you move forward and attend the consultation groups, because you want to have some awareness of actually what the field is and what the experts say, what the literature says. I keep up on the literature very well, and that's the least you can do. But I would say, you know, 6 to 12 hours before you can really say you have some academic competence or educational competence. But like I said, if you can actually get a certificate, go to or complete a certificate program, that's what I think is the best option, the highest standard, in addition to consultation.
So, you know, I've had this conversation with Dr. Ron Ross, who's the executive director of our Board of Psychology. And we've had this discussion. We were having this discussion early on, you know, and so the board is not going to say, hey, you've got to have this certificate or this training, because the board doesn't do that. And what the board would do would say, if there's ever a question about it, they're just going to, the board itself would defer to, well, what are the standards for, you know, the basic standards for, you know, the industry for this particular area of specialization? And does it look like this person was working on, you know, doing what was consistent with that?
And the reason those certification courses are good is because they will cover those standards, and they will introduce you to the current literature and all that.
They look at things on a case-by-case basis, okay? And then the other thing that you want to consider is the board recognizes that this is a time of crisis. And it understands if there's ever a question about anything that happened during this time, they would take that part into consideration. These are not to navigate. So, and so, you know, what they would do is they would take a look at this, and then, you know, they would say, well, first and foremost, your highest obligation is to connect with your client and see to their well-being. That's the first base that you cover. And if you're doing that in this time of crisis, then you've met the most important thing that you can do. So I know this is fuzzy, but I'm just trying to give you an idea of how this would work if there was ever a question that arose.
And I kind of along those lines, Jim, I would say, you know, now's the time to do it with less fear, because everyone understands the pressures of having to kind of do this.
Right.
So it's really an opportune time to do it and to develop competency in it.
This is Virginia Clark. I was wondering, any thoughts on why Medicare is not allowing the phone calls?
Virginia, I'm sorry, go ahead.
I mean, aren't phone calls HIPAA compliant?
Well,
Technically, no.
no, they
That's what I'm asking. Yeah.
Well,
no, because I mean, they're not monitoring. They're, you know, if you were reaching out to your client, to your Medicare recipient client, through a visual and audio component that was not HIPAA compliant, they would simply defer to, you know, the current HIPAA guidelines, which have been relaxed. But that's not the issue. See what I'm saying, Virginia?
I'm just asking what's the issue with the phone calls?
We're back to my, let's like trying to understand my cat.
right.
You know, if we think that our commercial insurance companies are difficult to understand, or their reasoning behind what they do is difficult to understand, and they certainly are, then certainly our federal government can be, you know, difficult to
Well,
understand.
think about it like this. What legislator, at least at the federal level, makes legislation based on personal experience with the legislation they're creating, or with how it will affect the average person?
Mm,
It's just not
mhm.
realistic. So they
No.
think you can just pick up a phone and, you know, talk to them, and or they don't think you should be able to pick up a phone and talk to your Medicare client who doesn't know how to use a cell phone, a smartphone, or Zoom or whatever, a video conference.
Of course, the irony, I don't know, Jim, if you were able to be there. I think it was last week, there was a forum provided by Medicare. But was it audio visual? No, it was a phone call.
Right. Yeah, actually, I couldn't go to that, and I'm hoping you took some notes for me.
Right.
Actually, I didn't. I think Michael might have, though.
Okay, good. I hope somebody did, because I couldn't go to that. But so but here's the one thing, though, that I think what I'm seeing here is that they're offering a compromise. In other words, they're throwing us a bone. So there's that separate set of codes that have been opened up to us, that they're not, that can be billed for what they're calling like audio check-ins. Okay, now they're not saying that you can use those codes to bill a full therapy service, but the definition of that code is, I'd have to go back and look at it, but you use the code to check in with your client, and it's for a briefer period of time. And so sort of like just staying in touch with them. Now, you know as well as I do, if you have a needy client on the phone, it's going to be really difficult to say, hey, I can do this with you, but I can't do that with you. They don't understand that level.
Right.
They don't get it. But what they're saying is, we'll give you this instead. And if you have questions about those codes, go back and look at my blog. I'm almost positive it was the more recent one, and I give you a link to the APA page for those codes and those code definitions, so you can see what they're defined as, and then you can go ahead and use those when billing Medicare.
Mhm. Another issue that comes up related to this is the internet is so overtaxed that many times I'm in the midst of an audiovisual conference call or you know, a session, and you know, one end or the other goes bad, and my backup plan is to call them on the phone.
Right.
Right.
And so I can't bill. I mean, fortunately, Ohio says telepsychology covers phone calls
right.
and video conferencing.
Right.
So I can bill it as a telepsychology session, but if it's a Medicare patient, that's a whole nother ball.
Right. That's why the insurance companies, the major insurance entities, including Ohio Medicaid, has relaxed their standards and say, hey, you can do therapy over the phone. That's why most of them have done that, because that might be the only means available.
Right.
You know.
Exactly.
And by the way, those standards, that change in those regulations, I'm fairly certain are temporary. And you know, within when things start stabilizing for all of us, they'll go back to their old guidelines.
That's what I was just going to say, Jim.
For that.
I think that's right. Yeah. So if you do end up doing this and incorporating it into your practice, you're probably going to have to rethink, you know, the rules again and the enforcement of them. And I'm sure they're going to go back to the way they were.
Although I kind of wonder if once the genie's out of the bottle, can you shove it back in?
Right. Well, I think that the law will catch up with the technology faster now, but I don't think all of the laws and rules are going to change, because some of them are going to be specifically applicable to this situation,
Mm-hmm.
especially HIPAA rules. They're not going to relax enforcement of HIPAA rules after this is done. I can't imagine that happening.
Yeah, right.
So I want to give one on this subject. I do want to give one more update that is that I actually didn't give in some of the previous meetings because it was just recently, the revision just recently came through. And so, as maybe I hope most of you have already heard, when you bill a teletherapy session to an insurance company, there still is that special billing procedure that you need to follow. And that is that you still bill the same CPT code, psychotherapy CPT code that you would have used before. But for your place of service, which for most of us, if we're in private practice, would have been 11. And in place of that, you use 02, which designates it as a teletherapy session. And then you also tack on the modifier. I'm so proud of myself. I remembered that word. The last time I did this, it's like, I couldn't even remember the words anymore. Modifier. The modifier, either GT or 95. And people have been asking me about, well, what difference does it make? I don't know. And people are kind of making things up, like, well, you use G for this company and 95 for that, or if it's phone only, you use 95. None of that's true. GT and 95, according to the standardized coding that we use, they're equivalent. Now, some of the companies have specified we'd rather you use this one or the other one. And if you go back and look through my notes in the in my blog and those recent messages that I've sent out, if a company anywhere has delineated they want one more than the other, I've put it in there. Now, this is the more recent update that I haven't given until now. With Medicare and Medicare only, if you're doing a teletherapy session, do not bill that 02, or it will lower your reimbursement rate. They are permitting you to go ahead and use the office place of service for a Medicare teletherapy session, which again, for most of us in private practice, it's 11. That's our standard place of service that we're using. So for Medicare teletherapy session, you're in private practice, use that place of service 11, as if they were actually there in your office. They have about 3 different reasons why they're saying that, but some of it has to do with being able to specify that you're that if you're in private practice and that you have that private practice overhead, they want you to be able to keep your full reimbursement rate. It matters more confusing.
Are you taking more questions?
Yes, absolutely.
Okay, this is Eve Whitmore, and my question is about Bureau of Workmen's Comp, injured workers, and who, what are the rules there currently in providing counseling to individuals who are workmen's comp?
Have you seen, Eve, any of the updates that I have sent out?
Yeah, I mean, I guess what I've seen is that they're only allowed to have telephone, and you have to get pre-authorization before you can do telephone.
No, I don't believe they are allowing telephone.
Really?
No. Have you seen? Are you looking at the updates that I send out?
Oh no, you know what? Actually, I apologize. I'm getting mixed up with. But anyway, workman's comp, that you have to get pre-authorization, and it would be the like the telepsych, but you cannot use the phone.
Oh, Matt knows.
I think that's what it is.
Well, yeah. So BWC's been allowing telehealth for a while. There is a telephone code that they allow if you're going to use the phone, but it's a lower reimbursement rate. And I don't think they wanted psychologists to use it, but I believe during this time they're allowing it. But at this point, yes, it has to be audio and visual, I believe.
Okay. So,
Now, I know someone who's on a BWC task force, Dave Schwartz, and I can confirm with him, there has been a lot going around, and I think they're presenting to the medical director of BWC their thoughts on best practices for doing IMEs via telehealth, and I believe it's going to be approved. So I really don't think BWC has an issue with telehealth, but I don't want to tell you something I'm not 100% certain about. So I can check with him, and if you want to send me an email, that'll be
Okay.
fine. I don't know if my email address is listed in here, but
yeah.
but you just would have to get the same C9 form completed and have all the authorization as you would as usual.
So here,
Inconvenient.
if you follow that link in the handout that you received as a part of this, then you'll see one of those links in there should lead you to my blog on the OPA website.
Okay.
The most recent message that I posted there, the most recent post that I did, includes the best detail that we have from BWC. Okay, it's right on there. And it comes from Dr. David Schwartz. And it says they will allow telephone-only sessions as psychotherapy, which has to be pre-authorized as per their normal rules, but will not pay it as at psychotherapy rates.
Right.
They want us to which pay much less.
I mean, with what the committee's doing with Medicare, trying to, or the same thing with workman's comp. I mean, I think it's just such a disservice because, I'm at home and I don't even have the case managers, who is that I contact? It's so amorphous. And meanwhile, my two clients, I've tried to hook them up with the audiovisual, secure HIPAA compliant, secure video, and, they don't know anything about computers. So,
Right.
so anyway.
I spend a lot of time doing these kinds of meetings and,
Yeah, I bet.
workshops and things like that, just trying to explain the rules and regs and all of that stuff. And, never once do I ever defend any of the things that they do.
Right. I know. I'm teaching to the choir.
But I will say this. I think that circumstances like this bring to our attention some flaws in our system. Okay.
Yeah.
And for those of us who are fired up about this, and I'm one of them, I've been doing advocacy work with OPA for a while now. For those who get fired up about this, please get involved and be a part of the advocacy effort. We have a BWC task force, and I'm sure they do. Don't they do, Matt? Do advocacy?
I'm on it. Yeah.
Right. So
that's David.
Think about that. This is a time for us to, we're not going to be able to solve it during this crisis, but this is a great time to get involved and start backtracking and saying, these are the rules of sanity that we all need to follow.
Well, yes, and good point, Jim. And one thing you have to remember is the rules and regs that we're following aren't necessarily coming from the legislature. They're coming from administrative rulemakers. So there's a law, but then how that's implemented is done by interpretation of the bureaucrats, and that's administrative rulemaking. It's essentially legislation, but not done by elected officials, done by appointed bureaucrats. So we do have access to them, and we can give our input to them. And that's exactly what these committees do. And then if you're as good as Jim, you actually, you can influence lawmakers, which I'm pretty impressed by.
Yeah, that's great. Thank you.
I have a question about location. So for a lot of these insurance companies, what I'm wondering is when you provide the service, Jim, you mentioned, the LO2, the location is mentioned as O2. What are we seeing in terms of what they require in terms of you being at your office, delivering the service versus being at a home office, for example?
Right. That's fuzzy. But, I'm not seeing anything from the commercial insurance companies that are defining, hey, that you can actually have to be in your office versus being in your home. Okay, I don't think it's defined. It's just they simply say that's teletherapy. Now, I think at one point with Medicaid, it was defined as being in your office. And then now here very recently, we've had those emergency rules that were issued that have relaxed that standard, and I'm fairly certain that can be at home. Medicare, I think Medicare says that you can be at home, but I have to go back and double check that. Yeah.
Yeah.
And we'll look through some of those guidelines that are on my blog. I think Medicare is okay with that too. I
And
think.
it used to be that Medicare made you go to your physician's office, your patient, and then they could see you at your office. But there are 3 different levels of risk, and the least risk is office to office. The next level is you're in your office and the patient's at home, and the next level is you're at your home and they're at their home. And all this stuff is covered in training, and that, in fact, home to home is a form of teletherapy that, you know, is in the literature. It is being trained. All that is part of the training, and you're going to cover that in, you know, in your courses, in your education. So it is recognized as an accepted standard. So we just have to determine which insurance companies pay what, and to see how that aligns with our state licensing board and the state laws. And Jim, as far as I know, there's nothing explicit about that in the psychology board rules, right?
Not as far as I know. No, they don't. I don't think they get that
Yeah.
specific. Ken's saying no. Ken's on the board.
What you would do is just make sure that you use best practices. You know, don't have your couch and your family in the background eating dinner. You know, I bought this this thing here, this a room divider. I bought that from Wayfair. Jim, you're used to seeing my background, but I just bought this for like $100, $120, and I paid $50 expedited shipping. And there, it's an instant office. You know, so it's just like, be conscientious about it. Obviously, everyone would, but you know, so you would be surprised at what some people do, and what some of the literature says that patients have reported their telehealth therapists doing. It's, yeah, just common sense, you know. As you would be in your office, you would do the same thing at your home office.
Mm-hmm. Mm-hmm. One follow-up question I have on that, and I guess this is kind of specific, but if you're doing this from your home, do you just like have a work cell that you use as a backup, or how do you see people handle that when they're?
What was that? I'm sorry, I didn't hear your question.
Do you have like a work cell phone that you use as your backup? Is that usually kind of how that works, or?
Particularly, my cell phone is a work cell phone, so patients have it. It's like my direct line. That's just how I operate, but everyone's different. Yeah, that's a good question. You would have to decide how you would do that. But, you know, obviously you would probably block the call or push *67 or whatever it is to disguise, to make it a private number. But our telehealth system actually has a dial-in enable number where you can actually use the phone line with an individual number and code, just like these calls, for each session.
Oh, wow. How cool. Yeah.
And then it's secure. So then you don't have to worry about the non-secure telephone line.
Sure.
You know, we have a tendency, because we think like this, and because in some ways we have insurance companies breathing down our necks and forcing us to think like this, but we get off into the weeds. And I would be really, really hard pressed to actually anticipate an insurance company looking back on a record that we have made for therapy that we have delivered during this time, asking us, yeah, I can see what you covered, and I can see how this fits into your treatment plan, and I can see that this was a teletherapy session, but were you at home when you gave this, or were you in your office? I don't think.
Right.
Sure.
Especially right now.
Right. Yeah. Thank you. Very helpful.
I have a question about, you know, like this recording function that this telehealth platforms have, and like what are the measures that what are the steps that we can take to safeguard against, you know, like clients recording sessions without us knowing? I mean, of course, that we can put it in informed consent that.
Well, here's what I would say with that.
Yeah.
If your client can record from the platform you're using, don't use it.
Okay.
It should never be an option. Now, technically, some of them have recording options, but for example, ours does, but we can't have access to it. They turn it off. It's for some other thing, you know, I don't know, but we do not have any access to any recording whatsoever. And if you have a telehealth platform that can't disable that, don't use them.
Okay.
What is the name of the platform you're using?
I'm sorry?
Oh, I'm sorry, I cut you off. I was saying, what is the name of the platform you're using?
We're using Secure Video. And we picked that one because it's going to be integrated into our electronic health record system. We did use Doxy.me, and they're very good. They're HIPAA secure, but this one seems to be working out fine. Now, Secure Video uses the Zoom widget. It does not use Zoom. It's just the widget, the little camera thing we're seeing, because it's through their own secure system. So it looks very similar, but if you scroll across the bottom, you won't see record in a secure video session. Everything will look the same, except there won't be a record option there.
I thought somebody else started to ask a question. Gary, got to unmute.
Uh-oh.
I can't hear you. You have to unmute. There you go.
There you go.
Okay. Just a follow-up question, Jim, on your most recent update about Medicare, and that was surprising that of all people, with the thing they have against the audio, the phone session, that they would accept the 11 location, which implies it's at the office.
Right.
But in addition to that, do you bill it just like you would in the office, or do you still have to put the modifier?
Yes, we do put the modifier. Did I not say that? Sorry about that. So it's your telehealth session would have your CPT code that you're using. Use your place of service 11 for the telehealth session, and then go ahead and include your modifier with that.
Okay.
Yeah.
Thank you. That's what I was asking.
You said that. My brain gets really full.
Jim, at the beginning of the session tonight, you mentioned that there were handouts that were linked to the email that we got. I didn't see that connection for the handouts.
We didn't get, did anybody else get a handout?
It's in the email. It's like there are two links. One is for the handout and one is for the Zoom meeting. I actually clicked the other handout one first, and that's how I figured that out.
Okay, I'm looking at the email right now, and
Let's see. So it says if it
Yeah.
clicking here is a HTML link. Please see information about our speakers and additional resources by clicking here. That's the actual link that takes you to the handout, and then the other one to join the call via smartphone or computer audio, the Zoom link.
all I'm saying is that thank you for registering for tonight's free online Q&A session, How to Survive the Pandemic. It gives the date, the time, and then to join, you click on this link. And then it has these phone numbers.
So you're missing the
then,
please see this line. I don't know why that is. But please see information about our speakers and additional resource by clicking here.
no, that's not there.
Oh, I don't know.
Hey, I'll drop it in the chat.
That's the email that's dated April 17th. That's the email I got today.
Yeah, that's
And maybe it was in the previous email. Was it a previous email?
Maybe it
No,
was.
today, actually. The one that the reminder email, it's that there is one sentence there. And if you click on it at the bottom of the bio for the panelists, there is a link at the bottom for resources.
What time, Jisan, when was that? Was that, did that come through today?
This morning it came.
It was this morning at 9 a.m.
Okay. I'm gonna
Yeah.
see what we're doing.
It's like right below that blue fonts, like date and time. And then
Okay,
there's
I just put it in the chat box
Oh.
if you want to copy it.
Let me see here. I think I found it. I found it. Thank
Excellent.
you. Appreciate it.
Got it?
Yeah, I got it. Thank you.
The most important parts of that, Dan, are the links. And, if you can get to the resource page and my blog, and then get my email address, which I'm hoping you already have, those right there will get you to everything. And if you can't find something, email me and I will get you to it.
Okay. Thanks again. Mhm.
Do we have other questions about any other topics? And I was talking a little bit earlier about like how the board would have sort of look at training in specialty areas on a person-by-person basis. Was I saying that right? Is there anything that you want to add to that?
Yeah, I think the main thing is the board looks at, what kind of training and education and experience you have in terms of competency regarding any kind of practice that you have. So rather than thinking of it as a specialty, it really is a competency area.
That's right.
I use that. I was just using the word specialty area because that's the word that Ron used when we were talking about this, or when he sent out the information.
Well, I use the word competency.
And in competency, determining whether a person is competent in that area is connected to, like, they just sort of evaluate that person's background on a case-by-case basis. Is that a good way to think about it?
Right. It would be if there's a complaint before the board about a practice, then one of the things the board looks at is, what kinds of training and education does a person have, the experience do they have to do the practice that they're doing.
Right.
If somebody's doing family therapy or doing neurological psychoneurological testing, how educated and trained or experienced are they in doing that? Just because they read a book or went to a workshop doesn't mean that they're competent.
I'm starting to feel like we've answered the questions and that everybody's feeling like they're in a good place with this. Does that seem true?
Finally.
Okay, well, what I would say is, feel free to reach out to me if you have a question about any of this or you come across something. And I think, Matt, do they have your email address too?
I don't know. Is it on that bio?
So reach out to me if you have a question for Matt too. If his email address isn't there somewhere, send it to me and I'll send it to Matt.
Okay.
Yes.
Okay, and really, for me right now especially, email is the best way to reach out to me. It helps me triage your questions, and they make sure that nothing falls between the cracks, even though it does sometimes. Okay, well, I'm glad we were able to have this meeting.
Okay.
And
Yeah,
appreciate
Thanks,
all of
everyone.
you.
Thank you.
Jim.
And Matt.
Bye.
Okay, take care, everybody.
All right.
Bye.
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 Thank you.